First speaker that I have this morning is Dr. Pat Allen. Pat has served as president of the American Academy of Periodontology Foundation, the American Academy of Restorative Dentistry, and the American Academy of Aesthetic Dentistry. He is the recipient of the Master Clinician Award from the American Academy of Periodontology and the President's Award for Excellence in Dental Education from the American Academy of Aesthetic Dentistry. In 2019, he was honored with the AAP Gold Medal Award. Dr. Allen has published over 100 articles in the area of aesthetic surgery and has presented numerous lectures and surgical demonstrations worldwide. Please welcome to the stage Dr. Pat Allen.
Thank you, Chris, and thanks to the Academy for the invitation to be part of this program. It's an honor. And thank all of you for being here for an early start. So you see my title. I'm going to speak about solving problems in the anterior mandible, which is the more difficult area to treat with any technique, and particularly with the tunnel technique. I need to cover my disclosures. I'm founder and director of the Center for Advanced Dental Education in Dallas. I have served as consultant for BioHorizons, U3D, and Perio Sciences, but I receive no royalties for the sale of any dental products. I'm going to start with a maxillary arch with just a case, because the maxillary arch is the easiest area to treat, again, with most any technique, and you can have success very easily. An example, you see a pre-op with multiple teeth with recession and sutured with human acellular dermal matrix, and then a 3-year outcome. And what I'd like you to notice when you look at different views, and particularly the smile, that there's just ideal aesthetics, complete root coverage, and a very natural outcome. So that's the advantage of the tunnel technique in the maxillary arch in particular. But if we go to the mandibular arch, we'll notice problems, and they are, I would call them challenges. And I think we find that our patients sometimes are reluctant to have treatment in that area if they've had previous grafts that they had some bad experience with. This is a report, a 10 to 15-year study, asking patients, would you be willing to have a graft again if you needed it? And that was negatively affected by mandibular sites, which we're going to talk about, by large areas, multiple tooth areas, and perceived pain. So if we look at challenges in the maxillary anterior area, they include muscle pull, frenal attachment, shallow vestibule, deep recession, tooth malposition, shallow recession, and KT width, among a few others. I'm going to hit on these primarily. And we're going to take the muscle pull and frenal attachment together. And if we look at this, the problem in the lower arch is retraction. How many of you have done a connective tissue graft with the standard technique and found retraction and found this a more difficult area to perform that procedure? I would think that would be fairly common. Well, the solution, if the problem is retraction, is tunnel. If you don't incise the papilla, you'll have an amazing stability of the area and elimination of the tension. So if you look at this is conventional treatment. You make horizontal incision through the papillae, drop verticals, dissect that flap back. If you use a connective tissue graft, you suture it in place, then cover it with that flap, and that causes problems. So I decided that it would be an idea to tunnel that midline papilla. So just make the incisions in the adjacent papillae, not the midline, drop the verticals, and then you have a tunnel and 2 pedicle flaps. So this is a clinical view of that. You can see that midline papilla is providing retraction resistance, because in this view, I'm using cheek retractors, and you just see no drawback of that tissue. And you can swing those pedicles without tension to cover the graft that's over the avascular root. So this was an interesting procedure. I published this in '99. This is a schematic from that publication of the graft being placed under that papilla and within a small tunnel. And then if you look at the suturing, this schematic drawing, I hate to show you my suturing because it looks a little messy. That's 5/0 chromic gut suture with a P2 needle. And you'll notice there's no exposure of anything. It's complete coverage, and there are cheek retractors in place, no retraction. So this is a 2-week outcome. What do yours look like at 2 weeks when you make that horizontal incision through all papillae? So this to me was a solution. There's 4 weeks, 6 months, and 20 years. So this is something that provides a good outcome. This is with palatable tissue, which is what I was using primarily in the 90s. And now a frenal attachment. Look at this frenum, and you see it's a broad attachment pulling at the margin, inflamed tissue, minimal attached dentary any place, particularly the adjacent central. So you see the ADM inserted and sutured, and a 2-week outcome. This is sort of average for a 2-week outcome. It's not the best, but it's, I think it's working well for an early no retraction example. And if we look at a 6-month outcome and at a year, what I'd like you to notice, we'll go out to 2 years, is the frenum. Look at the frenum initially, and then look at a very normal frenum at the 6 months and 2-year time point. That's from internal frenectomy. So you don't need to do a superficial frenectomy. Another case, a similar example, 2-year outcomes done in the same technique, 5 years, and you don't see the outcome you get with a free graft, of course, but what you're seeing is complete root coverage and a zone of natural-looking tissue. Aesthetics aren't the key in the mandibular arch, but what you need to recognize you're not going to see, as some of my friends like, a really thick connective tissue graft or free graft. So this is a little worse frenum. There's generalized recession, very thin tissue. It's a difficult area to do with a tunnel. So I'm going to tunnel it. I've made a modification I'll show you in a moment. But our plan is to treat all incisors, both canines and the left first premolar. So that's sutured, continuously sutured, the newer technique of suturing, 6-0 polypropylene, human acellular dermal matrix sutured in the tunnel, and a 6-month outcome. And that's okay. Again, it's not my prettiest 6-month outcome, but I'll show you a variety of different ones. Pretty happy with the 4-year outcome. Look at the frenum now. Doesn't pull on the margin. Look at the gain of thickened tissue, particularly the marginal tissue, and you see with this technique in the mandibular anterior region a good outcome. Now we get a little bit worse with the shallow vestibule, and what you're seeing now, in addition to shallow vestibule in this patient, a broad frenal attachment. You see the frenum actually coming out onto the mucosa. There is no attached gingiva, and root abrasion, pretty serious root abrasion, and some extrusion of the centrals, so a few issues to manage. I'm still going to tunnel with an allograft. That'll be followed with composite restorations to treat the abrasions. So the suturing you see here, graft has been placed in a tunnel. A little bit difficult to do with that narrow papilla, and I have to tell you that it did separate. I did not tear it. It chose to separate during my process of developing that tunnel. 4-week outcome, and you see a little bit of a deficiency in the midline due to that papilla separation, but I think we see a nice outcome at 2 years. At this point, there's been composite restorations placed, of course, but I think it's for that site, a nice outcome. But more importantly, what's happening to the vestibule? So these are finger retraction views of the vestibule. That's pre-op, and that's 6 months, and 2 years, and 5 years. So you see with the same manipulation of the mucosa, you see an extension of the vestibule that's been maintained. How does this happen? We'll talk about, but I'll tell you now, it's due to creating a rigid bed for that graft. A more recent case, really difficult to even get a photograph because the vestibule was so shallow. And recession, class 3 recession, no attached gingiva. So same technique, allograft on the surface, inserted and sutured. Here I did lateral closure, which I'm coming to speak a bit more about. And then you see a 2-year outcome. And the thing that's interesting, again, here is the effect on the vestibule. So you see a much more normal vestibular form. This patient had a very skeletally short mandible, and so you're not going to see a real deep area here. But I'll show you this with video. Here is a shallow vestibule problem with internal deepening. And pre-op, you see, if you look at her left quadrant, I treated that, and you're seeing a 20-month post-op. I had the patient back for a live surgery to treat her right side, and you can see preoperatively the form of that vestibule as I moved the cheek retractors. I did not expect to see this. I just noticed it while I was demonstrating for the group that will watch the surgery. And if you look at the treated side, 15 months after treated on the opposite view, and if you look at 6 months post-treatment, where you see a pre and post of her vestibular form on her right side. So it's pretty dramatic when you can examine it in that fashion. So how it works, you have to have a rigid bed. So I do blunt reflection for 8 millimeters apical to the CEJ. And that way you have a firm attachment of a dense connective tissue graft, whether it's allograft, a xenograft, or autogenous. So it attaches to that bed, and that will displace the frenum internally. It will displace minor muscle attachments and therefore deepen the vestibule. So this can be traced back to a paper from the 70s, and one of the authors was J. Siebert, as you see, and they placed 30 free grafts on bony beds and 30 on periosteal beds. Who would do that? And to see how they heal, I would have thought they would fail. All grafts were successful. Those half of those that were placed on periosteum showed mobility at 6 months, and there was no mobility on those that were placed directly on bone. Curiously, the ones placed on bone had less swelling than those placed on periosteum. So this is, I think, supports the concept of that rigid bed that I do and have the advantage of having overlying mucosal flap for blood supply to the graft. So let's look at deep recession. This is where it gets a lot more interesting. And clearly what we're doing with tunnel technique, it is a coronally advanced tunnel where there are limits on how far you can advance it coronally as you get into these issues of shallow vestibule and particularly deep recession. So I treated these without any change in the technique. I'll show you a couple. This is relatively deep recession on the canines, a little bit on the incisors as well, but great papillae. So this actually is a very good site to have complete root coverage. You see very little attached gingiva on the canines. Graft on the surface, sutured, continuous zinc suture, treating multiple teeth, I think 7 teeth in that case. And you see a 6-month outcome and 2 years, and I'll blow that up a little bit so you can see it better. And whatever parameter you want to measure, I don't measure gain of keratinized tissue because I don't believe it applies to a bilaminar technique. So you see thickened tissue, less root prominence because you have a graft beneath the surface of that mucosa. And this one was treated years ago as well. Generalized recession, pretty significant recession on the canine, deep wide we would call it. No attached gingiva there. So I'm going to treat this again with a tunnel. And that is the suturing. I used to do interrupted sling sutures for the overlying tissue. I don't do that now. I do a continuous sling. But nevertheless, that's the apparent sutured. And that's a 12-year outcome. So if you look at that canine before and you look at it at 12 years, you see complete root coverage and clearly thickened tissue and also a keratinized epithelial surface for whatever reason that shows up. It's, again, not a factor that I'm really concerned about. Problem is that deep recession can be really difficult to treat in the anterior mandible. So the solution is lateral closure. And this is something we published with Tony Sculian in 2018. And in the drawing, you see some sutures that I call connective tissue graft positioning sutures because you can't handle it in the same way that you do allografts and xenografts where you would not need those sutures. But you do need to suture the graft around the tooth with the deep recessions, and there's a knot on the lingual. I'm not happy about that. And then you see the lateral closure, and then we do sling sutures. So this is Tony's case from the publication. I just put the sling suture around the graft showing as a drawing, and you see a little bit of a crease in the graft. That's where it's suspended against the CEJ. And the positioning sutures are stabilizing sutures, and then lateral closure, and then the outcome. So this is a nice way to treat an area like that. In fact, I think you gain more keratinized tissue if you like, at least in a number of cases, because it's a double papilla flap essentially. So you're moving keratinized tissue over that root. This actually is the first one I ever treated in 2010. And if you look at it, it just screams lateral closure. There's no way you're going to advance that coronally to the CEJ, and it's an easy lateral closure. So it wasn't really a dramatic imagination to come up with it. So the tunnel was prepared, graft on the surface, inserted, and I did a single suture to close that opening with lateral closure. I do not freshen the margins. If you freshen the margins, you make the defect wider, and then you have more tension when you close it. And if you have a graft under it, you don't need to freshen the margins. So that's 6 weeks and 2 years and 5 years, just expected outcome, good coverage and keratinized surface. Do you ever see these where there's the reactive tissue at the margins? And you know when you see that there is proximal root exposure as well, and this tissue is very friable, so it falls apart when you're suturing or when you're preparing the site. And that's a continuous link suture and lateral closure to treat that site. And then you see a 6-month outcome. This is my favorite patient. See a significant recession, single tooth. And it's a lateral closure. I use 7-0 polypropylene for these in the anterior, especially for the lateral closure. And I'm moving keratinized tissue over. And that's a 10-day post-op. And the gentleman came back at 2 months. It's complete root coverage, a little immature looking. And at 8 months, it's okay. This is after cleaning. I didn't see him again for 2 years. He comes back at 2 years, and he's a pretty significant calculus former. And the thing that's interesting here is that in spite of the challenge of that calculus deposit, there's no breakdown of that lateral closure treatment. And then we just cleaned it. That's the same day, and it has a little bit better appearance than it had at 8 months. So let's look at tooth malposition now. And with tooth malposition, if you remember in the past at workshops, we said you graft first and then move the teeth second. And there were reasons for that that don't apply today. And I learned from my friend Giovanni Zacchelli that you move those teeth back into the ridge, and a lot of times these defects will improve dramatically, but you do it prior to surgery. And if you don't, I certainly have more difficulty having success with a prominent root in the lower anterior. So he brought this to my attention, a publication after I saw his presentation, and you see an example for me. And what I like to do is look at the lingual face of that crown. And if you see more of the adjacent teeth than the tooth with the recession, that's because that root's torqued forward. So you can make that diagnosis really easily looking from the posterior. This patient has a history of mandibular orthognathic surgery and a chin implant, which also impacts our treatment with a site like this. So we're going to align the root, the orthodontist does that, and graft with a lateral closure. So if you look at the lingual face of the tooth with the recession before orthodontics and after, you can see that they align, and now you know that root's been torqued back into position. And if we look at the pre-op, something to notice here, and again, learned this from Giovanni, that central incisor with the recession is a little bit higher, so it's catching the occlusion primarily first, I would expect, and then you put pressure on that and you can torque that root forward, perhaps using the arch wire as a fulcrum. So this is some theory. I'll let Giovanni tell us about that when he lectures. You're going to talk about that, Giovanni? He's not going to talk about that. So we'll talk about it after the session. So you see it 1 week after grafting with lateral closure and pre-op in 3 years. And if you look at the area of concern, you see it's a class 3, so it's not complete root coverage. But look at the thickness when you look at this laterally, and you see a really improved outcome, improved position of the root and thickening of the tissue. So it's the way to treat those. That's becoming a common treatment in my office. The patients go back and get the orthodontic treatment first, and then we graft. So let's talk about graft material just really quickly. This was a clinical review of acellular dermal matrix as an alternative to palatal tissue, and it's published in 22. And their finding was that ADM is considered an optimal option for treatment of patients with a history of orthodontic tooth movement for periodontal soft tissue phenotype modification. So there's evidence to support the graft, the material that I use. So one that I found particularly interesting, and I think we skipped a slide. Here we are. So this was a publication in Derm Therapy in 21. And it was state-of-the-art publication. They said that human acellular dermal matrix is the most physiologic scaffold to replace lost autologous dermis by adding structural support to soft tissues in almost all body parts by stimulation of functional new tissue rather than forming a scar. So let's look at crowding, last case on this topic. And if you have a problem like this, recession on the two centrals, they're close proximity, not much space for that papilla. If you try to elevate that papilla from the crest, it's just going to separate. And now you have a flap in the worst area where there's the greatest retraction. So what I did with this is I did a papilla access incision between the lateral and the canine. I'm going to talk more about that in just a moment. And did a lateral dissection and did not displace that papilla from the crest. So that was the tunnel method. And this is the 1-year outcome where you'll see very close to complete root coverage and thickened marginal tissue and a nice outcome in a little bit a more difficult site. So what I'm trying to do with this presentation is to talk about how we manage these challenges. Not we can't do a procedure, but how can we do the procedure? So that's the approach that I'd like to take. So now we're to shallow recession, and this is a fascinating area as well. And here's an example. I treated this patient who has just thin tissue, prominent roots. There's generally irregular bony topography, and in particular, there's a narrow sulcular perimeter for you to do the intracellular dissection, so it's more difficult. I treated this one that way. It's the way I was doing. I treated 8 teeth, and you see a 1-month outcome, and 3 months, and 4 years, and 7 years, and a pre-op in 10 years. And you see less prominence of the roots, again, because of that thick graft that's underneath that mucosal surface. So it's a new way of looking at things instead of using the parameter of gain of keratinized tissue as our basic outcome measure, primary outcome measure. So I'd been doing this particular procedure I'm going to show you for years and decided to publish it, and I just called it a papilla access tunnel technique to have a better access for dissecting the tunnel in difficult sites in the mandible. I prefer this for vascular reasons over submarginal vertical incisions. So this is the appearance, making incision in the papillae, just the facial aspect of the papilla between the lateral and the canine, and then that makes a little mini flap, sometimes called a W flap, and that gives us room to dissect horizontally underneath the 3 midline papillae. You want to retain all 3 midline papillae to distribute that tension over 3 papillae. So we just do that both sides. It simplifies the whole process. There's less risk of injuring the tissue when you do it. So we move on to the posterior in some cases, and then we extend the dissection beyond the 8 millimeters of blunt reflection by sharp dissection to get release of the tension of the tissue so we can advance it passively. And then finish this with, I did an arrowhead first. This is the modified Orban knife to make sure you don't have any retaining attachments that would block passage of the graft. And that's the graft on the surface, and inserting it and suturing. I've changed the suturing, I'll show you in a moment. A single continuous sling suture, but I had to go back and suture the incised papillae. I don't do that now. 24-hour post-op, and what I want you to notice here is the quality of that tissue at an early time frame. So there's minimal swelling, minimal inflammation. You've been kinder to the tissue. So that's a pre-op and 6-month post-op, complete root coverage, thicker tissue, and again, if you like to see a wide band of keratinized tissue, you won't be happy with this, perhaps. How would you like to treat this one? Look at the prominence of the roots here. Look at the deep undercuts. Shallow recession, a difficult site to do with the tunnel technique without access. So I did the papilla access and have the mini flaps, have the graft on the surface, and then insert it, suture, and again, I've changed the suturing a bit, but that's a single continuous sling suture. I had to go back and suture the papillae, so it's totally closed. And you see pre-op in 2 weeks, so it looks pretty nice at 2 weeks. I remove the papillary sutures at 2 weeks. I leave the continuous sling suture for 2 months because it's more comfortable to remove at 2 months and it causes no irritation over that time frame. So that's 4 weeks and 5 years and 8 years. So look at the difference in root prominence, look at the difference in the undercuts, and this is because, again, of that dense layer of allograft that's beneath the surface that does not resorb. If you use a resorbable graft, you will not get the same outcome. So this is quick videos. Show you this patient, and I'm going to show you them all at once, the initial incisions, and that's the papillary incision to start, blunt reflection, sharp dissection, papilla elevation, insertion of the graft, and a continuous sling suture. So due to time constraints, I'm not going to be able to show you all of these individually or all of them to completion, but just to give you an idea of the process. So the papillary incision gives you the access for your dissection process, and the papilla elevation I do with a younger good 7/8 curette. I'd be very careful. This patient had very weak papillae in the midline, so if you do a careful dissection, insert the graft through the one of the papilla openings, makes it quite easy and fast. Align it so it's lined up with the CEJs, and then start your continuous sling suture at the most posterior, work your way around to the opposite side and back. You have 1 knot when you do it that way. So I'm going to stop that because I've got more to show you, but here's a pre-op and 7-year post-op for that particular case. So this is what I want to get to. This is what I do now. I combine the papilla access with the lateral closure techniques, and I do the papillary access almost routinely. It just makes everything about it faster and less damaging to the tissues. And if there is even 3 millimeters of recession, not so deep, I still will do lateral closure. So that was a schematic of it with the papilla incision, You leave a papillary bed, and then you can dissect that tunnel through the deep recession site, which gives you access, or through the papillary incision, or both usually. And the difference here is then I do the lateral closure before I put the graft in. So I have an easier time of doing that more accurately. And then the graft is inserted and then aligned so that it does not extend over the papillary beds of the incised papilla area. And then one continuous link suture. So if you do the technique as I published it, you put the penetrations at root line angles. But where you have incised the papilla, make your penetration under the middle of the papilla so you can close that papilla with one continuous link suture. And then that also gives me more stability at the recession site because I wasn't using an extra suture there in the past, and so I use this continuous link suture for all teeth. So this is an example of a case. It's prominent roots, and that's not so deep recession, but I've done the dissection, site prep, papilla incisions gave me access to do that. I'm showing you a papilla open here. That's where I'll insert the graft, and I've already done the lateral closure. And then you see a graft on the surface, sutured, and 1 week, and pre-op, and 9 months. And you can again see less prominence of the roots, so you know there's a graft under that surface. And then a more recent case with pretty significant recession on one central and a little bit on the others, borderline class 3. There's a restoration problem here that I'm not going to go into. Sutured, and 24 hours, 6 months, and 1 year. If you look at the tooth in question, look at the gain of keratinized tissue and the thickness by combining these procedures. It's a nice way to do it. KT width, we can look at this really quickly. This is a schematic. You take that little section and look at it histologically at 6 months, and you go from the bone through the dense connective tissue graft to the mucosa, and that graft does not send a signal through the mucosa to tell that epithelium to keratinize. So you won't see that if you wait 20 years. I've showed you some long-term follow-ups. So I think functional tissue is a more appropriate term rather than keratinized tissue. Keratinized tissue has a lot of issues that you've probably heard me talk about, and my time is up, so I can't do it now. But I will show you this paper. This is by Tavelli and Barocci. And they showed that there was no significant difference in KT width observed across different bilaminar techniques, regardless of the graft material used. So it's like, thank you. Thank you, Lorenzo. Thank you, Cheyenne. And thank you, Gustavo, and the other co-authors for that paper. So I'm going to conclude with the challenges that I've discussed for you. You see the list, and what I will show you is the solution. If you have muscle pull, tunnel. If you tunnel the papilla, you will eliminate the retraction. So to me, that is the answer. Frenal attachment, you do internal detachment. It needs to be full thickness. So I do an initial intracellular incision to detach the soft tissue attachment to the bone crest, and then blunt reflection for 8 millimeters apical to the CEJ. That will manage frenum, and it will manage the shallow vestibule. Deep recession, the solution is lateral closure. Tooth malposition, do the ortho first. Shallow recession, the papillary access incision makes life so much simpler. Almost for all cases in the lower arch, I do that now. And KT width, use a non-resorbable graft. If you want to get a functional outcome, you need something that will give you a gain in thickness, tissue thickness, and a resorbable graft will not, so you need a non-resorbable graft. So with that, I'm going to thank you for your attention. I think I finished on time. I was told they had a hook. They're going to pull me off the stage. So it was a pleasure to be here, and looking forward to the next presentation. So a lot of great ones to come. Thank you so much.
Fantastic presentation, Dr. Allen. And yes, I have a hook backstage. I told each of them before we started, I have a very long shepherd's hook, and it fits right there. So, our next speaker this morning is Dr. Giovanna Zucchelli. Dr. Zucchelli graduated from the University of Bologna, Italy, with a degree in dentistry and subsequently received a PhD in medical biotechnology. He serves as a professor of periodontology at the University of Bologna and has received many awards for clinical research in periodontology in both Europe and the United States. He is a past president of the AAP Foundation Tarson Research Award in Oral Plastic Surgery and an active member of the European Academy of Aesthetic Dentistry, the Italian Society of Periodontology, and the Italian Society of Osteointegration, as well as the European Federation of Periodontology. Dr. Zucchelli serves as an associate editor for the International Journal of Aesthetic Dentistry, and is a member of the editorial board for the International Journal of Periodontics and Restorative Dentistry. Dr. Zucchelli has authored over 100 publications, is an innovator of several soft tissue plastic surgical techniques, and has taught the theoretical and practical surgical courses worldwide. Please welcome Dr. Giovanni Zucchelli.
Hello. You're a lot. I don't know if he said that I'm an honorary member of the American Academy of Perio. Did he say? It's something that I'm so proud of, you know. So let's try to start the lecture. This is my title, Subepithelial Connective Tissue Graft. I want to start immediately trying to change this paradigm. At the beginning, it was the graft that should cover the root, starting from the free gingival graft, and this was not effective most of the time. And so the flap was used in order to give some more blood supply so that the graft can survive on the root. Now, as you can see, the graft is really reduced compared to the root exposure in the very different indication that I'm going to cover during my lecture. And so this graft will never survive. This graft will never work to cover the root. And so this is the change of the paradigm. It's not the graft who is capable to achieve root coverage, but it's something that is going to be used to cover the root independently on the use of the connective tissue graft below. And what we are going to do in these 27 minutes is to understand when and why the connective tissue graft still has to be used, but it's not a bilaminar technique anymore. This is something I want to underline because it's very important, because this means a lot of reduction in the dimension of the connective tissue graft. That is something that the patient appreciates so much. So this is where we started, subepithelial connective tissue graft. And this is where we are going, subcoronally advanced flap tissue graft. And I will try to focus in the so-called very, very severe gingival recession. When a gingival recession is severe, when there is some periodontal or some other situation like tooth decay, the probing pocket depth, loss of attachment at the buccal aspect, and also loss of attachment interproximally, where theoretically it's not possible to achieve complete coverage. So this is the so-called periodontal gingival recession, nothing to do with aesthetics. And starting with the same topic of PAT, what I'm trying just to tell you that with the coronally advanced flap, there is no limitation in how much we can really advance our flap. So that's the great advantage compared to the tunnel. So even if you have a very deep gingival recession, the way we perform this flap is exactly the same, independently on the depth of the gingival recession, because we make the papilla design, and I'm very happy that also Pat started to elevate a lot of papilla, and maybe in the next year time I will convince him also to elevate that one of the tunnel. So if you place your papilla at the same distance from the vascular bed, which is the anatomic disepithelialized papilla, like is the advancement of the flap in the middle, the flap goes coronal passively. And this is completely independent on how deep is the gingival recession. Obviously, in the lower incisors, we have more problem, as Pat was underlying. We have the frenulum, we have a lot of muscles, we have the lack of the vestibulum depth, but these muscles that were covering the periosteum is physically removed from the periosteum, so to leave the periosteum completely free to be used for the anchorage of our suture in order to provide the increase of the depth of the vestibulum at the end of the surgery. Obviously, we treat the root. We apply also ADTA to improve the quality of attachment. We provide the vascular bed for the surgical papilla by means of the desepithelialization of the anatomic papilla. So we create a vascular bed that is as big as the dimension of the surgical papilla that we elevate at the same distance. That is the advancement of the flap in the middle. Then we go to the palate and we take a small connective tissue graft compared to the dimension of the root exposure. There is nothing to do. So it's not in relation at all. The connective tissue graft is used in this case for two reasons. The first one is because there is no keratinized tissue remaining in our flap, and we have to provide something to our flap that makes it more stable. And the second is that we can increase the depth of the vestibulum surgically with the use of the coronally advanced flap. But in order to maintain this depth of the vestibulum that was increased surgically in the long term, we have to apply a barrier. And this barrier is represented by the height of the connective tissue graft. So the connective tissue graft is chosen in relation to the depth of the vestibulum, genetically determined in this patient. And if there is very, very shallow, we look for 4 millimeters of connective tissue height. Now we place the papilla in the final position, and now we start to close the vertical release incision with the periosteal anchorage. Periosteum that was completely free from any muscles thanks to the removal of the submucosal tissue from the periosteum. So now at the end, we have a flap that is completely verticalized as much as the alveolar mucosa that we were able to free from the lip and attach to the periosteum level. So this is the patient at hand with 10 millimeters of the depth of the vestibulum. And this is the apical coronal dimension of the graft. And this was the situation of this patient at the beginning. There was no depth of the vestibulum remaining apical to the gingival recession. And we have from 12 to 13 millimeters of depth of the vestibulum. So this is something that we can achieve surgically. Now the muscles, the frenulum, as Pat was saying, comes back. But the barrier, which is represented by the connective tissue graft, don't allow these muscles and this frenulum to go more coronal than where the barrier is placed. So 13 millimeters of increase in the depth of the vestibulum with a coronal advanced flap, which is something that is exactly the opposite of what we are used to seeing, in which the coronal advanced flap is something that reduces the depth of the vestibulum. But this increase in the vestibulum depth is not because of the connective tissue graft, it's because of the surgical procedure. So you have to see at the end of the surgical procedure that there is an increase in the depth of the vestibulum that was obtained surgically. Second indication, why we have to use the connective tissue graft: when there is something wrong onto the root. In this case, tooth decay had to be treated, and there was also periodontal, endodontical involvement, so we have to close this small hole with some material that obviously is not the root. And if there is no root that is completely exposed, we need to apply some material that is, yes, compatible with the epithelium attachment, but for sure we will never achieve connective tissue attachment anymore. So in this case, the reason why we use the connective tissue graft is because we know from the beginning that there is the same quality of attachment that we can achieve when there is the root that can be treated, like in the case of before, root planing, ADTA, amelogenesis. In this case, there is an area of the root where there is also only glass ionomer, which is the material that is used in order to improve the quality of adhesion. But when there is adhesion and there is no attachment, we have to increase the thickness of the soft tissue much more, because it's the only way to maintain the tissue stable. So again, we remove the submucosal tissue, we treat the root, we remove the whole edges of glass ionomer from the root in order to expose as much as possible dentin onto which we can achieve new type of attachment, and then we prepare the vascular bed, and when we collect our connective tissue graft, this is again only used as a barrier in order to increase the soft tissue thickness in the area where the patient is going to brush, and where, in the case of trauma, we can induce gingival recession, because in this case, the recurrence of gingival recession is reduced because of the thickness of the tissue and not because, obviously, on the quality of the keratinization. This is the extraoral desepithelialization. We have to remove the whole fatty and glandular tissue from the graft, create a strip, which is 4 to 5 millimeters height. We stabilize it at the base of the papilla because this connective tissue graft really has to be stretched in order to work as a barrier to prevent the flap to shrink when the flap will meet this at the level of the cement-enamel junction. We restore the depth of the vestibulum that was reduced a lot because this was very, very deep gingival recession with the periosteal anchored suture, and then we finalize our coverage with the sling suture. So exactly the same procedure of before, but in this case, the reason why the connective tissue graft was used was not to achieve coverage, but because there was not the good quality of the root that makes the mandatory the use of something that increase soft tissue thickness. So this is also the long-term outcome of this case, which shows you something that I'm going to underline even later, that the increase in the thickness is much more with respect to the amount of connective tissue graft that we use at the time of the surgery. Another area which is always quite difficult to handle is the area of the molar, where once the recession gets to the depth of the vestibulum, we don't have further worsening of the depth of the recession, but there is a worsening of the level of attachment, so there is a probing pocket depth at the buccal aspect. The surgical technique is absolutely the same. If there is a pocket apical to the gingival recession, we have to remove the pocket epithelium, so we have to make a split thickness elevation also at the buccal aspect of the root, and then cytospecifically remove the epithelium. But again, this superficial incision allows the advancement of the flap as much as you want, and this is completely independent from the depth of reception depth. This is the removal of the epithelium of the pocket. We make root planing. There is a good quality of the root here, so we don't need to apply the connective tissue graft so much apical, but only the barrier. Amelogenics also improve the quality of attachment between the soft tissue and the root. Now we go to the palate. We take our strip that, as always 4 to 5 millimeters in height, completely independent on the depth of the gingival recession. We desepithelize it, and then we stretch it. Stretch means anchored to the base of the papilla in order to make this working as a barrier. Barrier means that when I try to push this connective tissue graft a bit more apically, it stays there. And so when the flap tries to shrink because there is no enough keratinized tissue remaining in the flap, the connective tissue graft will work as a barrier. Sling suture, first positioning, then closure of the vertical lesion incision with the periosteal anchorage in order to restore the depth of the vestibulum. First mesial, then distal, and then final sling suture after the closure of the vertical lesion incision in order to create such a seal of the marginal soft tissue to the convex profile of the crown. And this is exactly what we need to do in order to provide blood clot stability. And you can see also from the profile that the depth of the vestibulum was enormously increased surgically. So it's not the connective tissue graft that is used that makes the increase of the depth of the vestibulum in long term, but it's something that you can appreciate at the end of the surgery. And this is something that you can achieve only with the coronally advanced flap. The others technique that don't separate the flap from the adjacent alveolar mucosa will not allow you to achieve increase in the depth of vestibulum surgically. It's something that we achieve only in relation to the dimension of the connective tissue graft. Remember how much connective tissue graft I use here? No more than 4 millimeters in height, and look at the increase in the thickness and how much this connective tissue graft is increased in long term, not only in thickness, but also in height. And this is something I will come back. What is another indication? So this is the so-called Miller class 5 or Cairo class 7. So something that doesn't exist in the literature because we have gingival recession, but we have a loss of attachment that is much, much more than the depth of the recession. And obviously here the surgical technique is a bit different. It's not only a mucogingival surgery for the treatment of the gingival recession, but it's also a regenerative procedure that makes the papilla preservation from the palatal aspect. The whole supracrestal soft tissue is moved from the palatal to the buccal aspect, but then the flap is advanced in order to be able to coronal and cover completely this strip of connective tissue graft that is applied only in the coronal area. When the defect is very big, we can ask the help of the collagen substitute in order to complete the coverage of the bony defect without taking too much connective tissue graft from the palate. That is completely useless in the most apical area, because the role of the connective tissue graft, again, is to work as a wall. Wall means barrier, means that in this case it's not working only to prevent the flap to shrink, but also to provide stability to blood clot in the suprabony and infrabony component. We always have to completely cover the connective tissue graft, and this is the must of the surgery. Leaving the connective tissue graft by definition is a mistake, and I will show you also why. Because the objective, as Pat was saying, is not to increase the keratinized tissue, is to increase the quality of the connective tissue that functionally can allow the patient to clean very, very well. So you see that in this case, a combination of the connective tissue graft wall used as the strip and the collagen matrix in the most apical aspect allow to improve also blood clot stability to the infrabony component of the defect. But the key is the role of the connective tissue graft in the most coronal area to prevent flap shrinkage and collapse. So the advancement of the flap, you see there is a complete coverage of the root of the cannon of the premolar, but the objective of the treatment was not complete coverage, was also to improve the periodontal support. And this is only the 6-month radiograph with some very, very important in such a short period of time remineralization of the bony defect, and this is the 5 years outcome that shows you again. Remember how small was the connective tissue graft, and look how big is the increase in the thickness. And now, when you look at the radiograph, you can see that there is a complete remineralization together with the root coverage. But root coverage was not achieved because there is improvement of attachment, because improvement of the attachment is something that occurs after root coverage, which was completely achieved at the time of suture removal. So look at the 5 years outcome and a higher magnification, the bone peak distal to the cannon that was completely restored without using any bone filler material inside the defect, but only amelogenins. So again, let's go back to our question. What is the subepithelial connective tissue graft? It's not only something that we love, because sometimes when you leave it exposed, or when unexpectedly it gets exposed, it's a problem. And maybe you can try to convince the patient, look, what's a nice increase in the keratinized tissue I create to you. But the patient is not happy. In Italy, patients don't like keratinized tissue. In Italy, patients like that there is no difference between the tooth and the adjacent teeth. And when the patient comes to you, because there is an exposure of the connective tissue graft, this is one of the most difficult interventions. Again, we have to ask the help of the coronally advanced flap. And since once the exposure of the connective tissue graft starts, it goes further, we have to make this intervention before that there is the complete exposure of the connective tissue graft, and there is still some amount of keratinized tissue remaining of the covering flap that we can use to be advanced more coronal and to cover the connective tissue graft again that will be desepithelialized intraorally. So in this case, a coronally advanced flap for multiple gingival resection was done. The graft that was exposed was desepithelized with the same technique that we use for the desepithelization of the free gingival graft when we use the technique of free gingival graft desepithelized. And now we have to move this flap in coronal direction, again with the same technique, superficial incision to remove the all muscles. And the very, very difficult thing of this case was the proximity of the frenulum. Like Pat was saying, we never remove frenulum from outside. Frenulum is very nice alveolar mucosa, highly vascularized with some more muscles. And we have to remove the muscles, the insertions from inside the frenulum, the deep with the deep incision, and the superficial with the superficial incision. So this frenulum becomes inactive. Then it will come back, but now there is the connective tissue graft that working as a barrier will allow this frenulum not to pull anymore to the soft tissue margin. So this is the desepithelialization of the previous connective tissue graft, which is performed as always like we do for the papilla with the blade and the microsurgical scissors. We have to refine this very, very carefully, because if we leave some remnants of epithelium, there is high risk that this becomes exposed again. So the microsurgical scissors is more probably the instrument that allows you to refine this desepithelialization in the best way. And now we can use our coronally advanced flap and use this sling suture at the base of the papilla where the frenulum is inserting, in order to block any movement that by the frenulum can be transmitted to the papilla that has to be left absolutely passive above the vascular bed of the anatomic desepithelize. But again, the concept is full coverage, because when the connective tissue graft becomes exposed, we have to be very religious. We have to go to the church and pray that the color, texture, and surface characteristics is very similar to the ditch and teeth, because if it's not, the patient don't like. And maybe you can try to tell him, oh, look, what a nice keratinized tissue, but this doesn't work in Italy, dear friends. So this is the desepithelialization, the coverage of the small amount of keratinized tissue that was remaining apical to the exposure, the passivity of the frenulum, and you can see that there is a good healing. But the concept is try to make this intervention when there is at least some minor amount of keratinized tissue that is remaining apical to the connective tissue graft exposed, because if the connective tissue graft becomes fully exposed, it's very difficult to convince the patient that there is good increase in the keratinized tissue height. So this is the emergence profile, and this is the profile and the smile. This patient is very, very happy, and she was not happy at all despite the increase in the keratinized tissue. But let's go back to this increase in the keratinized tissue. I show you this case that I like so much. It's very rare that I divide the surgical treatment of gingival recession in the lower incisors in such a way, but in this case, it was nice for me because there was one of the central incisors that was perfectly healthy, and so I took the opportunity, please forgive me, to see what happens if I treat one side first, and then I will look at the other side at the time of the second intervention. So please take a look at the lateral incisor. Concentrate your attention to the lateral incisors. You can see that there is 0 remaining keratinized tissue at the beginning, and in only 8 months, you see that there is about 1.5 millimeters of keratinized tissue coming back. And the question is, where do this keratinized tissue comes from, since there was no exposure, since there was no keratinized tissue at all to start with. And now try to look at this better magnification. This is the lateral incisors, 0 keratinized tissue. This is the barrier, 4 millimeters connective tissue graft. So not subepithelial connective tissue graft. It's the Kelly connective tissue graft. Very, very small, very, very thin. It's stretched and used only in the coronal area. You see that there is an area of root that is exposed, more apical than these 4 millimeters. The advancement of the flap with no keratinized tissue remaining, and in only 5-6 months, there is some keratinized tissue. When was the time of the second intervention? I took the opportunity to take a picture in the area where I did the vertical release incision at the level of the lateral incisors. And here we are about 1 year, it was 11 months after the surgery. And look, this is by definition, dear friends, is the distance between the soft tissue margin and the mucogingival junction. That for all of us is keratinized tissue, by definition. This is, dear friends, alveolar mucosa, because you can see the vascularity of the alveolar mucosa, and there is no keratinization of the epithelium. And so the question is, where do this keratinized tissue comes from? And look at it inside. What is the connective tissue that we have inside these 2 different tissues? Keratinized tissue, alveolar mucosa. Same. The connective tissue graft that was taken from the palate, which is underlying both the keratinized tissue and the alveolar mucosa. And what this tells you, it tells you that when you use a connective tissue graft and you completely cover it with a coronally advanced flap, the keratinization of the tissue follows biology, not the exposure. Biology means the realignment of the mucogingival junction that will make the color, texture, and surface characteristics of this tissue exactly like it was before gingival recession was occurring. But when you pull the lip during the picture, you see the so-called hidden graft. Look at this patient, same patient, 1 second, 1 second, 1 second. Look at see again, same patient. What do you think the patient liked most? Do you think the patient liked to see this sort of soft tissue tumor? But remember, what was the connective tissue graft I used? And if you don't remember, I will show you. This is the connective tissue graft I was using in this patient. And look at the increase in the thickness that this patient had in 5 years' time. This is the connective tissue graft, and this is the area where when I pull the lip, you see the increase in the soft tissue thickness, and by ischemia, you can see a sort of keratinization that likely the patient is not capable to appreciate. And why this happens? This happens because the root, like the bone, goes in palatal direction. While when you make the coronally advanced flap with the verticalization of your flap, the flap is really verticalized. So the part of the flap that is covering the connective tissue graft is separated thanks to the presence of this connective tissue graft that works as a space keeping and keep the alveolar mucosa with no keratinization at all separated from the root. But the area that is just apical to the connective tissue graft, it's an area where there is great stability of the blood clot thanks to the verticalization, the anchorage of the flap to the periosteal bed that will be easily colonized by the connective tissue graft, which is immediately above. So we don't need to use big connective tissue graft. We don't need to use, because the increase in the thickness is something that we can see not only in the buccal lingual dimension, but also in apical corner dimension during the long-term follow-up. While the keratinization of the tissue, so the color, texture, and surface characteristics, depends only on the genetics, depends where is the position of the mucogingival junction. In the upper jaw, like in this patient, take a look at the canine. In 5 years' time, how much is the increase in the keratinized tissue height? But also this patient was treated exactly with the same technique, small amount of connective tissue graft, and very, very, very minor amount of keratinized tissue that was remaining apical to the gingival recession was moved coronal. So this was the amount of keratinized tissue end of the surgery, and compared to the amount of keratinized tissue that this patient has in 8 years' time, but no difference. This is called, dear friend, biology. This is called realignment of the mucogingival junction. So what is the role of the connective tissue graft in this case? It's not to increase the keratinization, but it's to allow the patient clean with functional, good quality of connective tissue for the time it takes for the mucogingival junction to go back to its genetically determined position. So in this new scenario, the connective tissue graft is not anymore what we need for achieve root coverage, but it's something that we can achieve only with the use of the coronally advanced flap. The problem of the coronally advanced flap is that cannot provide us long-term stability in this coverage of deep gingival recession, because when the mucogingival junction goes back, the soft tissue margin also can shrink, and so we need the connective tissue graft. When we need to increase long-term vestibulum depth, yes, I can increase 13 millimeters the depth of the vestibulum, but if I don't apply the barrier, this will be reduced when the muscles comes back. When we need to increase soft tissue thickness because there is a bad quality of the root or, for example, implant, and when we need also periodontal regeneration and allow the biology to work. Thank you very much for your attention. Thank you.
Absolutely amazing, an amazing video that we see there with Dr. Zucchelli. This next gentleman, Dr. Mike McGuire, it's a pleasure for me to introduce him because in 1995, as a first-year periodontal resident, I had the opportunity to go hang out at Mike's office for a day, and it was absolutely wonderful. And over the past 30 years, he's been very influential in my career, helping me run clinical trials in my office and resulting in publications. So it's just a real honor to have the opportunity to introduce Mike. Mike graduated from Baylor University with a degree in psychology and then obtained both his DDS and Certificate of Periodontics from Emory University School of Dentistry. Dr. McGuire is a past chairman of the American Board of Periodontology and was president of the American Academy of Periodontology and the AAP Foundation. He serves on the editorial boards for the Journal of Periodontology, the International Journal of Periodontics and Restorative Dentistry, and the International Journal of Oral and Maxillofacial Implants. Dr. McGuire has received numerous awards from the AAP, including the Clinical Research Award 3 times, the Robinson Regeneration Award twice, the Master Clinician Award, and the Gold Medal Award. Dr. McGuire has authored more than 50 scientific articles and textbook chapters. He's also presented more than 200 continuing education programs, lecturing nationally and internationally. Please welcome Dr. Mike McGuire.
Thank you, everyone. Thank you, Dr. Richardson, for that very nice introduction, and thank you to the organizing committee for the invitation to be here today. It means a lot to me. You know, as required, these are my conflicts of interest and dual commitments. I am founder and chairman of the McGuire Institute. It's a not-for-profit practice-based research institute, and the following companies have provided research funding in the last 12 months: Asua, Identical, Dentsply Sirona, Celtherix, and Implident. But I always maintain complete control of the content of my lecture and reporting of all data. So in the next 28 minutes, I'm going to give you a whirlwind tour of the last 30 years in search of alternative tissues. We also will spend a little bit of time going over ways to develop and implement a decision support system, and we'll be looking at alternatives in these 3 broad areas: in scaffolds, signals, and cells. Spoiler alert for those of you who are not yet ready for one of my major conclusions, and that is no one, including us, has yet found an alternative to the gold standard autogenous tissue that is as good or better. And we may never. But that doesn't mean that we shouldn't keep looking. I think everybody would appreciate an off-the-shelf alternative. I know I would. I've been talking about this forever, just like you guys have. This is my first publication on root coverage in JADA in 1990, and in the discussion, among other things, I talked about the limitations of the palatal donor site. You know, there's just a finite amount of tissue we can harvest at any one time, potential morbidity. So all of us were looking for alternatives. At that time, guided tissue regeneration was a big deal in osseous surgery, in regeneration. So could we leverage membranes to be able to do this? So here we have a large area of recession on this central incisor, and we're going to use a titanium reinforced EPTFE membrane. And I didn't go to the palate right, but does that mean there's no morbidity to this technique? No, it was not uncommon, as you see, to have tissue dehisce over membranes. So even other techniques that you don't go to the palate are not always without problems. In this case, we ended up with a pretty good root coverage on this central incisor, considering all the defect factors that we had to overcome. But nonetheless, we always were continuing to look for alternatives. About this same time, Mike Newman and I published the very first papers on evidence-based dentistry in periodontics. And that changed things. Prior to that, it was acceptable for all of us to stand on stages like this, show beautiful cases, and suggest that if I can do it, you probably can too. But following this, we now were beginning to create a database and evidence based on periodontal treatment and strategies for clinical decisions. And from that moment forward, anytime we're talking about treatment, we need to be able to support that by evidence, not based on opinion or your experience. Prior to that time, very few of us had ever even heard these terms, level of evidence or strength of recommendation. Today, anytime we're going to suggest treatment, we have to be able to support it with the evidence. All of the studies I'm going to share with you today have relatively high evidence. All of them are randomized controlled clinical trials. I remind you that TikTok, Instagram, and YouTube are today's version of case reports, opinion papers, and letters. Not necessarily good to rely upon to guide your daily treatment. Just as important as the level of evidence that you're going to rely upon is where was that evidence created? All of the studies I'm going to show you today, the evidence was created in practice-based research. And what that means is the outcome should be relevant to your practice. Practice-based research does a lot of things, but one of the most important is it provides treatment that takes place in a real-world environment on patients that are representative of private practices, not studies done in environments that could never be duplicated in your office on patients that look nothing like your patients. And that means that the results should be results that you can use to treat your patients come Monday morning. The FDA has realized the importance of practice-based research and real-world evidence. In fact, today, if you're going to run a study through the FDA, you have to demonstrate to the FDA how you will produce real-world evidence. Reason for that, the reason they're sensitive to it, is over the last decade, many of the studies that the FDA oversaw themselves, the outcomes didn't look like anything that was going on in the real world, especially as it relates to implants. And there is no research modality that can produce evidence-based, real-world evidence better than practice-based research. In addition to that, practice-based research allows us to provide long-term data. You've seen cases this morning with Pat and Giovanni where they're showing long-term. We want to see long-term data. You know, we're looking for alternatives to the gold standard, and these gold standards have been around for decades and decades, 20 to 50 years, depending on what you're looking at. I'm very hesitant to suggest an alternative that I don't know how long it's going to last. I hate to tell you, but most studies only go out to 6 months, and everything works at 6 months. I want to know what happens at 3 years, 5 years, 10 years, longer. And it's very hard to do that with anything other than practice-based research. And the reason we can do that is because the subjects in these studies are patients at our practices, and they hang around. And so we're able to bring them back and see what's happening long-term. So with that background, let's look at some evidence-based alternatives that we might consider as alternatives to autogenous tissue. These are the studies that I brought to share with you that we've done. They're not all of our studies, but I think they are representative of our studies, and they reflect also the broader evidence base, studies that other people have done as well. I don't think anybody has looked at alternatives in a more methodical way than we have, and unfortunately, time's not going to allow me to go through these studies in any detail at all, but all of them are published in peer-reviewed journals. They're available for your critical review should you decide that you want to do that. I think our time is better spent on kind of just running through these, giving you an idea of what's available, and then talking a little bit about developing a decision support system to help us understand when or if we might want to use some of these alternatives. So let's begin with the extracellular matrix scaffolding, primarily collagen-based scaffolding, and we'll start with this study using a xenogenic collagen matrix versus connective tissue graft for root coverage. This is a collagen 1 and 3. It's interesting material because it does well both covered and left exposed, and there's very few matrix that you can say that. In this case, here is a picture at 1 year of one of the cases. You see the xenogenic collagen matrix at the top and the connective tissue at the bottom. Very nice root coverage, good aesthetics, no visual signs of inflammation. And if we look at our objective outcomes, what do we see? Well, it's actually improving over time. And at 12 months, we have 99% root coverage with our connective tissue graft and 89% with our xenogenic collagen matrix. Well, what do those numbers really mean? They don't mean a lot sitting there by themselves. How about if we need some benchmarks, don't we? So let's ask the broader evidence base. If I have a Miller class 1 and 2 recession and I want to use a connective tissue graft, how much root coverage would I expect at 6 months to 12 months? And the answer is about 89%. So how did we do? Well, we knocked it out of the park, and we'll talk later how we might be able to do that. But how did we do with our xenogenic collagen matrix? We achieved the amount of root coverage that you would expect to achieve with a connective tissue graft, and we did it without a donor site. Also interesting, we actually achieved slightly more keratinized tissue with the xenogenic collagen matrix graft than we did with the connective tissue graft, and we know the connective tissue graft is genetically encoded to have keratinized tissue over it. So there is a lot of evidence out there. A lot of new evidence, but they're long-term evidence, but happen to be newly published, about the importance of keratinized tissue as it relates to preventing recession and to maintaining health. So if you're looking for root coverage, but also your patient needs keratinized tissue, this might be an alternative to keep in mind. So how does this material do over time? These are the same pictures I showed you at 6 months at 5 years. And if we look at this statistically, there was no significant difference between any of these therapies between baseline and 5 years, meaning they hold up very well at 5 years. So that's good, important information for we as clinicians to know. I mentioned this material works well uncovered as well as covered. So here we're going to use a xenogenic collagen matrix, compare it to the free gingival graft, not for root coverage, but for increasing keratinized tissue. We find that we're able to generate 4.4 millimeters of keratinized tissue with the free gingival graft and about 3 millimeters of keratinized tissue with the xenogenic collagen matrix, but the patient-reported outcomes were highly in favor of the test of the xenogenic collagen matrix. It came out with better color, texture. Obviously, they liked the surgical experience better because there was no donor site. Well, how does it do over time? And I bring to your attention, we recalled at 6 to 8 years, 23 of 30 subjects. That is incredible. And you can only get that type of recall or be able to bring that many patients back with practice-based research. And what we found was not only did things maintain over time, we actually increased the amount of keratinized tissue at 6 to 8 years than what we had at 6 months, probably due to creeping attachment. Interesting material here. This is a different type of collagen matrix. This is a volume-stable collagen matrix that we're going to compare to connective tissue graft for root coverage. It's a multi-center practice-based trial, an RCT. This is one of the subjects that we published in the manuscript. And in this case, of course, you know, everybody shows their prettiest cases. This is one of the prettiest cases, so everything looks great. Great root coverage, great phenotype modification, both with the connective tissue graft and the volume-stable graft. Unfortunately, things don't always work as well. And so if you look at the plot here, you see that we put in the circle there, that about 17% of the patients didn't do as well. That dropped down the percent root coverage, and so in this RCT, the test was inferior to the control, the connective tissue graft, to the tune of about 71% versus 94% root coverage. However, if you're interested in increasing the soft tissue thickness, the volume-stable graft did a pretty good job. What we found was this material is pretty technique sensitive. It's not particularly easy to suture. It doesn't do as well over prominent roots, and it's easier to work with if you have a wider papilla. So you have to be more careful with your patient selection here than perhaps with other materials that are more forgiving. But we had less postoperative pain because there was no donor site, and we did get increase in volume. We use this same material to increase the phenotype around existing implants, comparing it also to connective tissue. Now, this is an interesting study along a number of lines. This is one of the most thorough soft tissue augmentation trials ever done. We had 7 investigators at 5 practice-based centers across the United States, and we evaluated 36,000 data points. No stone was left unturned. And we employed very sophisticated technology to measure phenotype modification. Big difference from what we did in the past with an endophile and stopper. Now, most of us think, you know, improvements in technology are always great things. And they usually are. But in this case, the improvement in technology almost entered a new confounder. Because what we found was that we now can measure with our technology changes that you and I can't see, changes that our patients can't see, yet we are having to declare a winner based on things that are not observable. So that's probably going to be even a more concern as we move out into the future with even better technology, and this emphasizes how most of these alternatives, we need to look not so much at objective outcomes, especially outcomes you can't even see to choose a winner. We need to look at patient-reported outcomes, and we'll be talking about that as we move through the lecture. And of course, this brings back the age-old argument of statistical versus clinical significance. That said, at 1 year, clinical outcomes, thickness and volume, and PROs were similar to connective tissue versus the volume-stable graft. And there was, of course, less time and pain associated with the volume stable rather than connected tissue because no palatal donor site. Now, we almost always do a pilot study before we do an RCT, and I brought this one because I thought it might be interesting to the audience. It has been submitted for publication, so it's currently in peer review. Interesting study. We're looking at traditional acellular dermal matrix versus a new microsurfaced acellular dermal matrix. And a couple interesting things in the pilot. This pilot only goes to 3 months. It's looking there, and the primary endpoint is 14 days because the sponsor was interested in what happens in early healing. And you can see dramatic change in early healing. Acellular dermal matrix at the top, microsurface ADM at the bottom. If you look at 14 days, you see that in an exposed environment, the acellular dermal matrix looks dead, probably is. And if you look at the microsurface, you see it's incorporated. But what's surprising, if you look at 30 days, it all looks pretty doggone good. You know, classic literature would tell you, you don't use acellular dermal matrix in an exposed environment. I told the sponsor that. You're crazy wanting to run this thing. It's not going to work. Yet, at 3 months, both of these are producing a nice zone of keratinized tissue. And what we found was the microsurfaced provided faster healing and earlier integration. Now, there's again a fairly good amount of evidence suggesting that early healing events affect long-term outcomes. We need studies here to prove that with this material, but there's clearly a difference in early healing here. Also, we did histology on these also, and that too was different than what you would expect with classic literature. The classic literature says histology on acellular dermal matrix used in this approach is going to look like a scar, but it didn't. Both acellular dermal matrix and the microsurfaced, when we looked at our histology, it was a normal connective tissue with a keratinized surface. So, for those of you who already use acellular dermal matrix as your go-to as an alternative to connective tissue, this may be a material you might want to keep your eye on. We'll have to see how the studies work out as we move forward. Let's shift gears now and let's move to another category. Let's go to biologics. And the first biologic approved in periodontics and dentistry was an enamel matrix derivative. It was approved based on bony regeneration, but the FDA was generous. When they got FDA approval, they had a broad label and it includes soft tissue, but they didn't have any soft tissue studies. So, I'm seeing a void there. I said, well, let's do some soft tissue studies. So here are a couple studies where we were looking at connective tissue graft versus coronally advanced flap with EMD. And what we saw was that we were able to achieve 94% root coverage with our connective tissue graft and 95% with our enamel matrix derivative. But more surprising was complete root coverage. We achieved complete root coverage 79% of the time with connective tissue graft and 90% of the time with our enamel matrix derivative. How about long term? Believe it or not, we were able to bring back enough of these patients to get statistical significance for evaluation at 10 years. And what we found was at 10 years, everything was holding up well. Either procedure were equal, whether it was connective tissue graft or the enamel matrix derivative. Well, this is a biologic. Is there a value added? We know that connective tissue grafts will not going to create regeneration. But will we get that with a biologic? Is there a value added here? So this is the largest human histologic study done that we published a number of years ago looking at a biologic to cover previously denuded root surfaces. This is one of our control teeth, looking at it with micro CT as well as histology. And you can see that we're able to achieve 100% root coverage. You can see the CEJ there, but all we have as far as the attachment is just a long junctional epithelium and connective tissue adaptation to the root surface. Very different than what we saw with our test teeth. We had 7 out of 9 of our test teeth had evidence of regeneration, with this one on the screen being the most dramatic. You can see bone growth all the way up the previously denuded root surface, 100% root coverage, and a nice biologic width attaching into the tooth up there. And the conclusions were that, yes, we can get root coverage basically with whatever we want, with connective tissue graft or with chronally advanced flap with an enamel matrix derivative. But if you want true regeneration, if you want new bone, new cementum over old cementum, and functionally ordered PDL, in this case, it's going to take the addition of a biologic enamel matrix derivative. About that same time, I was fortunate to be an investigator on the pivotal trial where recombinant PDGF was FDA approved. And this was one of my cases in that pivotal trial upon re-entry at 9 months. And photographically, it appears that we have supracrestal bone growth. And I'm thinking, wow, supracrestal bone growth? Well, what can we do with soft tissue? Like an enamel matrix derivative, when they got FDA approval from this study, they had approval for soft tissue applications, but no studies. So let's do some studies. So here we did a pilot. We got good results from the pilots. We have proof of principle. Let's take that to an RCT. And here we have a 30-patient RCT comparing chronally advanced flap and connective tissue versus PDGF. And at 6 months, photographic evidence of nice root coverage, no visual signs of inflammation with either test or control. And if we look at our objective outcomes, we achieve 91% root coverage with our PDGF versus 99% with our connective tissue. And here at 5 years, the same 5-year pictures of the same patient I showed you at 6 months, everything appears to be holding up good, and if we look at it statistically, no difference between baseline and 5 years. Everything is doing very well. Again, this is a growth factor, so what kind of value add do we get? If we look at these patients here with micro-CT and histology, again, you see there's your CEJ, and your sulcus, your biologic width, that's the newly created osseous crest, the gingival margin, and that's where the original gingival margin was. So we have new cementum covering old cementum, new osseous crest, functionally ordered PDL. So here is a case where the alternative outperformed the gold standard in the attachment. We actually achieved true periodontal regeneration. Let's move to the last category, and that's live cell technology. We have more experience in live cell technology in the oral environment than anybody else in the world. We did a number of studies on various live cells, matrices, and this is the study that we ran that achieved FDA approval of the first live cell device in dentistry. A material called living cellular construct. We compared it to the free gingival graft, again, not for root coverage, but for increasing KT. Very interesting material. It's 2 layers. The upper layer is composed of living keratinocytes. The lower layer composed of living fibroblasts. They're producing collagen. Both of these cells are cross-talking and talking to the defect, to the native environment, producing all sorts of glycosaminoglycans, growth factors, things needed for healing and regeneration. So here's one of my cases in the trial where we have free gingival graft on the far screen with the living cellular construct closer to me. And at 6 months, what do we have? Well, let's look at the free gingival graft first. Were we successful? Yeah. Everybody in this room could do that. You know, has that kind of tire patch look. It's functional, not particularly aesthetic, but it worked. Well, you know, the reason it looks like that is because that tissue doesn't belong there. This tissue comes from the palate. It will always maintain its palatal phenotype, no matter what you do. Look at the LCC at 6 months. Here we had just freely movable mucosa, and at 6 months, I think you can appreciate a nice mucogingival junction and a nice zone of keratinized tissue. Can you tell I was there? No. This material doesn't act like a graft. It does not engraft. This material causes site-appropriate differentiation of the cells. It guides the cells that are supposed to be there into the area. That's where we want to go in the future with tissue engineering, to be able to generate tissue that's indistinguishable from what nature intended. We also use the patient's own fibroblasts. There's a study, this is, to my knowledge, this is the only RCT ever been done looking at closing open interproximal spaces. And in this case, we're going to use the patient's own fibroblasts. We're going to take a small biopsy from their palate. We're going to send that to the laboratory. The laboratory is going to break the cell lines out, grow the fibroblasts to 200 million fibroblasts per ml. We're going to do what we term the papilla priming procedure, and that is just a small surgical insult into the papilla to get a little swelling, to give us room to be able to inject. And we're going to come in then and inject into the papilla, not a filler, but the patient's own living fibroblasts. So these fibroblasts, they set up housekeeping, they produce collagen and thicken the dermis, closing the open interproximal space. So here, after the papilla priming procedure, we have 3 different injections, a week apart, either placebo or 200 million fibroblasts per ml. And if you look at the center panel, I'll show you a time lapse from day 0 to 4 months following 3 different injections. So look at the middle panel there. So we have proof of principle. Take a lot more work, a lot more studies to show, is this possible in a predictable way, but interesting. So, as we conclude, I have shown you a number of examples as alternatives to autogenous tissue. And they all have different attributes, right? Some are better at root coverage. Some are better at increasing KT. Some are better at thickening the phenotype. Some are pretty difficult to do. Some are easy to do. Some are expensive. Some are free. Autogenous tissue is free. And some can even create true periodontal regeneration. So how do we know which one of these we want to use, or maybe ones that I didn't talk about? Well, whether you're a pilot flying an airplane or you're a periodontist treating a patient, having a decision support system will be of great help as you make this decision. And the first thing we want to look at is what's the strength of recommendation for each one of those alternatives and the other alternatives I didn't show you. You know, what's the level of evidence? Do you have systematic reviews, meta-analysis, or do you have a couple TikToks and an Instagram? All of the ones I showed you have RCTs, so relatively high level of evidence. Do you have real-world evidence? All of the studies I showed you were practice-based studies. They should be relevant to your practice, not data that comes out of a study that you could never duplicate in your office. Does it have long-term data? Again, we're comparing things to our gold standards that have been around forever. Everything I've shown you has long-term data with it. And finally, numbers of studies. Is there only one study out there? The papilla one I showed you, only one study, so probably can't really count on that a whole lot. But do you have enough studies that meta-analysis and systematic reviews can be made? And do you have other studies that come up with the same results as our studies, confirmatory kind of studies? So you want to look at what's the strength of recommendation for each one of these alternatives. Then look at what does the patient bring you here? What's the patient bring to the party? Are there local behavior and systemic issues that you can control or you can't control? If you have a lot you can't control, you may want to use autogenous tissue. It's more forgiving. I guess the same thing could be said about defect factors, but you can also use defect factors to help demonstrate which one of these alternatives might be better for you. For example, if your defect factor is a lack of keratinized tissue, choose an alternative that's good at creating keratinized tissue. If one of your defect factors is a thin phenotype, choose a graft that's is predictable at changing phenotype, thickening phenotype. Surgical factors. What are your clinician reported outcomes? You know, how easy or hard is this to do? Do you need special instruments to do this? Do you need special auxiliary? This is where alternatives may actually outperform the gold standard. The other surgical factors have to be put in also, you know, flap tension, flap thickness, all of these things play a role. But one of the most important are patient-reported outcomes. You know, what is the patient demanding? Why do they need this? The patient-reported outcomes is a wide range, from signs and symptoms all the way to quality of life. But again, you can use that to choose which alternative is best. If they're concerned about recession and sensitivity, you better be using an alternative that's really good at root coverage, right? If they're concerned about eating ability, maybe they just have freely movable mucosis. You need to be choosing an alternative that's good about increasing KT. Time, costs, discomfort, predictability, you can balance that with the alternative. So alternative therapies will likely be chosen, not on objective outcomes. We may never find an alternative that is as good or better than the gold standards based on objective outcomes. We are going to be looking at alternatives based on PROS and based on ClinROS. An example of how these decision support systems work well, I love this plot that Chambrone and Pitty-Prado published in JP in 2018. On this side is and it's 49 RCTs. I've highlighted some of our studies that are part of this, but you can see that in the 1990s, they didn't get as good a root coverage as we're getting in 2020. Well, why is that? Connective tissue is not any better in 2020 than it was in 1990. The reason we're better at that is because of our decision support systems. We know these factors that are important. We can control them. And I've inserted here some of the alternatives that I just showed you, and you see they are doing well as you compare that to the broader database. So our practice alone has published 8 different papers looking at alternatives to free gingival grafts. We published 10 different papers looking at alternatives to the connective tissue graft. I've shown you some of the ones that I think are the most appropriate, but even the ones that didn't make the cut, don't take them off of your radar screen. You've got to remember that it's very rare for an alternative to the gold standard to be adopted in the first or early versions. I mean, think personal computer. Think about Apple I computer in the 1975 compared to the iPhone today. Think about internet in 1990. You need to avoid the trap of the first version. And so even if the first version is not all that good, you need to apply what's called the silver bullet test. And that is, you know, I don't really love this alternative, but if it were 10 times better, what would it be? If you'd say, yeah, I still wouldn't love it, then life's going to go on with another gadget. But if you say, you know, it's not too good today, but if it were 10 times better, I could find a use for this. That would be cool. In fact, it could even be disruptive. So you need to discipline yourselves to separate the quality of the early version from the long-term significance and impact of a new technology. Our ability to identify emerging trends is essential for discovering tomorrow's opportunities, and discovering tomorrow's opportunities allows us to move forward in a very rapid-paced world. Thank you for joining me on this journey.
I would like to introduce Dr. Otto Zur, who obtained his degree in dentistry from the University of Aachen. He is a board-certified specialist in periodontology by the German Society of Periodontology and runs a private office together with Dr. Markus Herzler in Munich, Germany, which is dedicated to periodontology and implant dentistry. With more than 25 years of clinical experience in teaching practice, Dr. Zur has become a proven expert in his field well beyond the European borders. He has served as a board member for the German Society of Periodontology, and he presently holds an associate professor position in the Department of Periodontology of the Johann Wolfgang Goethe University in Frankfurt, Germany. Dr. Zur has written several refereed scientific articles in the field of periodontology and implant dentistry, and his book, Plastic Aesthetic Periodontal Implant Surgery, was published in 2012. Today, his research activities are focused on oral soft tissue wound healing and oral soft tissue reconstruction. Please welcome Dr. Otto Zur.
Thank you very much, Chris. I don't need to say it's really an honor for me to be part of this. So I will, as the last one more time, focus on connective tissue grafts and hereby try to look at it from a broader scope. Also look at it from a different perspective, and this way maybe add some more clinical relevant information for you. I didn't need to mention, oh, excuse me, I have no conflicts of interest, no commitments, this just as an addition. I don't need to mention in front of this audience that the application of soft tissue autografts has probably characterized the last 60 years of clinical periodontology, mainly with 2 different targets being pursued: increasing the width of keratinized tissue and increasing soft tissue volume. Hereby, the free epithelialized graft is considered as the gold standard material to increase the width of keratinized tissue around teeth, and today, most probably even more important, around implants, whereas the connective tissue graft is considered the gold standard material for increasing soft tissue volume in many indications today, such as gingival recessions, as we have seen, alveolar ridge preservation, soft tissue reconstruction around implants, pontic site development, papilla reconstruction. So we use it in many, many indications. So if we look at this connective tissue graft, we look back on 45 years research and clinical experience. So most of us would think there have no more questions remained, you know. And this is to some extent also true. Almost all clinically relevant questions have been addressed scientifically and also have been answered scientifically. However, till to this day, and everybody in the room knows that, sometimes in rare situations, we still do see difficulties that we cannot explain based on current knowledge, and they cause significant problems for our patients. And this is now exactly the idea of my talk today. So I would like to, first of all, share with you the gold standard and recall if this is really a gold standard. We will then focus on some wound healing challenges if it comes to soft tissue autografts and discuss if there are any benefits or shortfalls depending on where and how we harvest such connective tissue grafts at the human heart palate. We will look at some clinical consequences, maybe try to work out some practical clinical guidelines to best possibly control the wound healing outcomes. And if there is some time left, we can also have a quick look in future developments. So let's get started. These soft tissue autografts are normally harvested at the lateral heart palate, including the tuberosity area. For this reason, it's important. It's important to understand, at least to some extent, the composition of the masticatory mucosa at the palate, because this is actually the tissue we are using for our soft tissue augmentations. Very briefly, just by using this biopsy for illustration purposes, we can say that the masticatory mucosa at the palate is composed of 3 different layers. It's the covering epithelium, and it's the subepithelial connective tissue with the lamina propria and the submucosa. Looking at the epithelium, which is characterized by orthokeratinization, it's something between 300 and 600 micron thick, depending on where at the palate we look at. We can actually say it's very similar to the gingival epithelium. The lamina propria, as we all know, is from clinical experience very dense, very coarse tissue. We have a lot of extracellular matrix packed with collagen type 3, 1, fewer type 5, type 6. We have hardly any elastic tissues in this layer. It's composed also of 2 different layers. We have superficially the papillary portion showing finger-like protections into the overlaying epithelium. These finger-like protections, so-called retipics, are 200 to 300 micron long. Under it, we have the reticular portion, which is characterized mainly by thick reticular fibers in the extracellular matrix. The submucosa, in addition, is nothing else but subepithelial connective tissue with a high proportion of glandular blood vessel tissue and adipose fatty tissue. Just as a side note, looking at the tuberosity area, this consists of lamina propria only. A submucosa is most of the time not present in this area. The thickness of the masticatory mucosa of the palate is also very relevant for us. Very relevant for us. What we can say from many cadaver studies that are available is that there's a very high variation in the thickness from side to side at the palate, from patient to patient. Based on concrete numbers, we can say it's something like, in an average, 3.5 to 4 millimeter thick. If you look at it more in detail, just for the very beginning, we can say that the thickness of the masticatory mucosa increases from the canine to the second bicustid. It's getting thinner at the first molar, here's the palatal root most of the time, and getting thicker again at the second molar area. Also important, the thickness of the masticatory mucosa increases, starting from coronal to apical towards the raphe mediana. If it now comes to possible donor sites, we have to also respect the neurovascular bundle of the great palatine artery that needs to be respected. And taking all this together, and this is now important for me, we have different areas as clinicians where we can harvest connective tissue grafts. We have the possibility to choose where and how to harvest such connective tissue grafts. We have the anterolateral palate, so in between canine and second bicuspid, where we have a lot of tissue. We have the second molar most of the time, and we do have the tuberosity area that gives us the possibility to harvest connective tissue grafts. And looking at our profession from a broader scope, somehow everybody is doing a little bit different depending on where you have been educated, depending on where you live. It's always done a little bit different. So here, for instance, very typical area to harvest connective tissue grafts is the tuberosity area. So here, distal wedge technique, classical wise. We use the trapdoor approach quite frequently in the second molar area. Typical wise, single incision technique at the anterior lateral palate, and more than ever, as just been shown before, the de-epithelialized free gingival graft, which has been made very popular by Giovanni Zucchelli, as you just have heard. So we have different possibilities. More in detail, we can say, well, if you decide to harvest such a connective tissue graft after a flap elevation, we need thick tissue. This is we find in the, you see this on the right side, in the premolar area, in the tuberosity area, sometimes lateral of the second molar. If you decide to harvest a free gingival graft that you're going to de-epithelialize, you have much more possibility. You are far away from the great palatine artery, and this gives you, of course, more possibilities to harvest such connective tissue grafts. Important is, if you look at these harvesting procedures, so here, typical wise, the single incision technique at the anterior lateral palate, an access flap is prepared, meaning that the epithelium, including the superficial portion of the lamina propria, is in the flap and not in the graft. In consequence, the graft derived from a single incision technique or from a trapdoor approach is no difference, mainly is composed of deeper portions of lamina propria and submucosa. Very different if you look here at a free gingival graft harvesting procedure, a graft which is de-epithelialized outside the oral cavity later on. So it's already here visible, it's the opposite. The flap is now the graft. In consequence, if the epithelium is removed, after having taken care of the wound here at the palate, the graft is mainly composed of the superficial portion of the lamina propria. So a very different tissue composition also by looking at it. And last but not least, distal wedge technique in the tuberosity area, also beautiful area to harvest connective tissue grafts. If the wisdom tooth is not present, similar to it, the epithelium needs to be removed in this area. So also a very good area to harvest connective tissue grafts. Why would I share this with you at the very beginning? We said the connective tissue graft is the gold standard material today for soft tissue volume augmentations. However, since we have different possibilities and since different techniques are applied by clinicians, this gold standard is not so clear. And just by looking at the screen, what you see here, all 4 of them are autogenous connective tissue grafts harvested at the human heart pellet. But they look very different. They look very different. They have a different geometric shape, depending on the amount of obtainable tissue in the different donor sites. This is not that much of a problem. We can fold them, suture them together, we can slice them, unfold them, but they also do have a different tissue composition. Of course they have. Of course they have, because they have been harvested at different sites at the pellet with different harvesting procedures. The question is now, do these different tissue compositions have an influence on how these grafts can be successfully used in daily clinical routine? Well, what we can say from the literature is for sure that when we use connective tissue grafts from the pellet, this tissue is genetically determined for keratinization. So this is coming from the 1970s. We can even more say today, based on some research, that this tissue, even that keratinization depends on where we are in the tissue. So let me go with you through some aspects, which are important from the healing perspective, looking at different tissue composition. We have not the time to talk about revascularization, but we can talk at least quickly about the epithelial differentiation, the keratinization as just mentioned, and we can look at volume stability. I don't want to be misunderstood. We could share now many beautiful cases. Connective tissue grafts have really proven success. We can be enormously successful, independent of the indication, with soft tissue volume augmentations using connective tissue grafts. This is not my idea today. I want to focus with you now rather on possible problems, rather on possible failures. This way, maybe inducing a discussion that would help us in the future to avoid these problems. First of all, looking at epithelial differentiation. So we can say the keratinization of the masticatory mucosa is genetically determined. We can even guess, based on early clinical studies, that the inherent morphogenetic stimuli for keratinization are the more powerful the superficially they are in the masticatory mucosa at the palate. This might explain that if you first of all looking at connective tissue grafts harvested deeply in the masticatory mucosa are quite forgiving in terms of hyperkeratinization. I'll show you a clinical example here. Here, for instance, a recession. I left it exposed without praying, but it worked finally very well. And this is something which is not surprising for me. I'm used to that. However, if now instead of a connective tissue graft deeply harvested, you would use a de-epithelialized free gingival graft, the outcome might look different. And this has also been demonstrated and shown in scientific investigations. Here they had on one side where a tunnel technique was used to treat gingival recessions with a de-epithelialized free gingival graft, big aesthetic problems that do not surprise me, because here, one of my examples here, de-epithelialized free gingival graft has been exposed, and typical-wise, you see the demarcation zone, you see the keratinization that looks from an aesthetic point of view very unpleasant. This is something I had for myself personally painfully to learn. The de-epithelialized free gingival graft has been developed to be completely covered by a coronally advanced flap. You don't leave this exposed. It behaves different to a deeply harvested connective tissue graft. You can run into aesthetic problems. This might also explain why sometimes, obviously, superficially harvested connective tissue graft can, through the flap, cause hyperkeratinization. This is something we find rarely. It doesn't happen too often, but sometimes it happens. And if it happens, we are in a bad situation if patients do show The question is, why does it happen? Only maybe in 1 out of 50 patients, in 1 out of 100 patients. This is something we cannot explain. Is it maybe the thickness of the flap that it can go through? Is it maybe a specific host reaction? Is it maybe external factors that can play a role? Or is it maybe even epithelial remnants we might have left on the connective tissue graft after de-epithelialization? And this is also something that more and more shows up in the literature. It has been more clinical experiences. If you talk behind the door to clinicians, well, sometimes there are problems that we cannot explain, but more and more this is also anchored in the literature. Here it's a big RCT, so more than 60 patients treated with a coronal advanced flap on one side with a single incision-derived graft, on the other side a de-epithelialized 3-gingival graft, and they've seen not rare major complications with the de-epithelialized 3-gingival graft. So here, for instance, cul-de-sac formation. I don't know if anybody in the room has ever seen that. I have seen this not only once, so deep invaginations. We can see a re-epithelialization of the graft. Now you might say, Otto, you did something wrong. And probably you're right. My argument, I'm not proud on that. I'm not proud on showing you this case example, but I think if it can happen to me, it can also happen to you. And if this happens in the middle of the face and patients to show, we are in a very bad situation. How would you correct that? And if it's only 1 out of 200 cases, this must be avoided, and we have not understood why these things can happen. What makes me really nervous is that sometimes this can also happen over time. So here, for instance, the situation, here this is the not so bad after 12 months, and this is after 3 years. So it also has to do something with time, And if this happens, I really cause problems for the patient, I really cause problems. One more time, if there's only 1 out of 200, this must be avoided in the future, and that's why I find it very important to discuss it. Also, cyst formation has been demonstrated in the literature. Here it's another prospective cohort study. They showed in 15 to 16% cyst formation after using de-epithelialized 3-gingival graft. I cannot imagine that this reflects the clinical reality. I've seen this too, but it's very, very rare. In my clinical world, this is very rare. Again, but if it happens, we are in trouble. So here you see the situation. It's very difficult to treat. This is let's say, a plasty liquid that's coming out there. It's embedded in soft tissue if you go in with a probe. So these things can happen and can cause problems for our patients. That's why this needs to be discussed. The same is true for volume stability, and we heard this before. It's quite evident, that harvesting superficially, we get a lot of stability. One graft that has not a good reputation in this sense is the tuberosity graft. Because not only by clinical experience, also in the literature, more and more it becomes evident that this graft has a tendency for hyperplastic reactions. Is this very often? In my clinical reality, it's very rare. One more time, if it happens, if you look at this case, for instance, this is a 3-unit fixed partial denture. You see in the center a pontic, so a good outcome. You don't even see the problem. If you retract the lips and use flashlight, you might guess what the problem is. If you look occlusally, the reality comes if you sit opposite of your patient. I removed it already twice, but it seems to come back. Does this happen often? No. But one more time, if it happens, we are in a bad situation. The patients are in bad situations, and that's why it's so important to discuss these possible failures. The same is true, again, now talking about a single incision-derived graft. And to make things very quick here, we use this in our group in a RCT looking at 2 different techniques for root coverage. Different to studies been done before, we used volumetric analysis. Okay? This gives us the possibility to look at the 3rd dimension over time. So we could exactly follow the thickness of the augmentation we did here using a connective tissue graft derived from a single incision technique. And if you were looking at it, we could clearly see, if I wanted it or not, that from the 1-year outcomes you see on the left to 2 years and 5 years, there was ongoing shrinkage. Okay, so from 1.6 thickness over the previously exposed root surface after 1 year, we lost something like 0.3 millimeters over 5 years. This tells us a connective tissue graft derived from a single incision technique used in gingival recession therapy seems to undergo shrinkage, even over time. If you look at a deepithelialized free gingival graft in a different indication, this is not so important at that point, but here it could be analyzed that the opposite is the case. So also here measuring the thickness of the achieved soft tissue thickness over 5 years, the tissue was increasing thickness. Is this good news? This is very good news. So this seems to be more stable, rather a tendency for thickening. However, this can also go in very rare situations in the opposite direction. So here a clinical example, the roots were covered with a deepithelialized free gingival graft. Now we jump 2 years ahead. So sometimes this can also go in the wrong direction. You know? This is rare. This is rare. But if it happens, we are not in a good situation. So at that point, which graft is now the better graft? There is no discussion. And I think I can also only just follow the other speakers in the morning here. The right one is the better graft for many reasons. I have not the time to discuss this in detail. For many, many reasons, this is the better graft. However, and this is important for me to discuss on the stage, it seems to bear in rare situation risks, risks that can cause problems for our patients, and that's why it's so important to talk about it. So what can we do now with this information? And now we start to become very empirically. I cannot refer to research, what you can do and what we do today without knowing it better. I would always remove more epithelium. Without knowing if this has a big impact, I want to remove everything, every retipic. So instead of 0.5 millimeter, rather a 0.5 millimeter to 1 millimeter. The same is true for deepithelialized free gingival graft, different to former years. I remove more, I harvest thicker and remove more of the epithelium just to be sure. Is this the solution? I don't know. What could be a way in the future we could look at is to flip it. If it would be true that the inherent morphogenetic stimuli for keratinization are the more aggressive, the more superficially we are in the masticated mucosa of the palate, it might make sense to flip it. And this is something we are looking at in detail at the moment. It's a lot of work, but we are quite far, using the lower anterior just as an example to better understand what could be done in that sense. So here it's a split mouth design, and always one graft is a little bit exposed, the other one is under the flap, just to be sure that we have under the light microscope all necessary informations. So here in just one example where a deepithelialized free gingival graft, as you can see it here, was positioned. So some of them covered, some of them exposed for the later biopsies. So this is a typical outcome. You see it thick, it's a very stable situation, but the parts of the connective tissue graft being uncovered looks more like a free gingival graft in an area without aesthetic relevance in this study. On the other side, we do the same technique, but now we use the same graft and we flip it. Again, part of it covered, part of it exposed. We have biopsies from both scenarios to better understand if this would make a difference. Here you can see it's already different to what you've seen before. And last but not least, we compare this as a control to the regular, let's say, connective tissue graft harvested with a single incision technique. So this looks different, From a biological point of view, I don't want to say that this is what I prefer in this area without aesthetic relevance, but I assume that we will at least have some more insight in the near future if it would make sense to flip such connective tissue grafts regarding the outcome. So for the future, what is important, to overcome these problems that we discussed? Maybe one focus could be for us as clinicians to be safer in the removal of the epithelium, during the de-epithelialization. So we could think about chemical possibilities, laser technology could play a role, and interesting is also the good old removal of the epithelium with a diamond burr. I hated that, I did it many years ago, but today it might look a little bit different. So here's an interesting study from a former student from us from Romania. He compared the deepilization with a blade with the deepilization with a low rotating disc-like diamond burr. And you can see on the picture that the red apex are somehow pulled out with this low rotating diamond burr. So maybe this is one area we should look at in the future to avoid the problems that we do see. Maybe we can combine connective tissue grafts, combine the advantages, the disadvantages. So here, tuberosity graft with a single incision derived graft, or deepithelialized free gingival graft, folded, covered by a single incision derived graft to have both advantages, disadvantages. Deepithelialized free gingival grafts in different orientations. So this might be one thing we can look at. But last but not least, the final goal, and we heard that, must be to avoid any grafting procedure at the human heart palate. This is, at the end, the most important thing. The problem is, to get there, And I truly believe that this is going to be not so easy, That's not going to be so easy, if we don't go from a scientific point of view in a bit of a different direction, because the question is, for me at least at that point, how should we ever be able to develop a soft tissue substitute material, really measuring up with the gold standard, if we have not understood the gold standard yet? Thank you very much for your kind attention.